Given that we're almost 20 years into this, and a couple of us have been in practice since the beginning of this. I don't know, Brian, if you were around in 2000 when this started, but I'm dating myself. What's your opinion as to why CMS has deliberately chosen to stay out of or to shy away from the dispute resolution process yet again in this, and just to keep it internal, not it's almost like it's a third rail to CMS with this, and yet it's the source of essentially why we're back here again trying to clarify this is based on perceived abuses by payers from providers of this whole process over the last 2 decades.
Yeah, Kendall, I mean, that's a great question, and I wish I had an answer for that. I mean, I'm not aware of any statute or regulation that would prohibit CMS from granting appeal rights, except for the non-interference clause. And you know, I think most of the hesitation that that CMS has in getting involved into disagreements between contracted providers and Medicare Advantage plans, it typically boils down to payment, right? I mean, the services typically have long been provided and boils down to whether something should be paid, and that, I guess, in CMS's previous interpretation, has gotten close to a particular price structure for payment. Now, I think that CMS is very very careful in this proposed rule to not address payment for services, at least how services should be paid. But again, to define that these are that inpatient hospital care, access to subacute rehab, access to inpatient rehab hospitals or facilities, they are basic benefits. I mean, CMS specifically called out those three, inpatient admissions, SNFs, and IRFs. That access to that is a basic benefit, and so yeah, I mean, it's not an answer to your question, Kendall. It's a great question. But CMS, to my knowledge, doesn't have anything in there that addresses the rights of contracted providers, because they expect it to be in the contract between the Medicare Advantage plan and the provider.
Yeah, I mean, I guess my opinion would be, I think from my interactions and some of the listening sessions with CMS, and now seeing kind of the significant, I think, regulatory change in posture with what they're proposing here, is that I think it used to be perceived as mainly a payment issue that should be handled in the realm of your contract. Because what I don't think they really understood, and now I think the provider community has come out and been able to bring it to the forefront, was how difficult or sometimes how convincing plans can be that keep patients and providers from pursuing appeals, and sometimes how burdensome and how hard it is to actually appeal a decision. I don't think they had full understanding for benefits, for instance, post-acute care. How if a patient calls, it's going to be an hour and a half with a bunch of barriers. If you get cut off, there's no protection. It's really a burden to appeal some of these decisions. So I think they felt like their oversight was in place on the benefits side, which is not, you can't contract away provide a patient's benefits. So if they have the right to post-acute care, that's not a provider payer issue, that's a patient benefit issue. And so I think what they didn't fully understand, and I think the provider community has given enough examples of, physicians think that plans don't cover post-acute like they do for Medicare. And I think they realized that the 5-level appeal process that they thought should be easy to pursue actually has been much more challenging, and people are no longer pursuing it like they would for something like Medicare. And so I think what really got them interested now to change this is that the OIG pointed it out now in 2 successive studies that were very prominent. And then it aligned with, I think, the majority of providers' experience, which is, wow, they really are not covering what Medicare showed from a benefit standpoint. And then from a payment standpoint, I do think that where this regulatory change, I believe, will have a benefit to providers. If you're not contracted, it should at least level set that you're going to be able to appeal your payment denials similarly like you would a Medicare denial, in that you can go through the 5-level appeals process. From a standpoint of, if you're contracted, obviously CMS will not get involved with that. But what this will do is that if you pursue dispute resolution, issue-specific dispute resolution, which most contracts have a way to say, we don't agree with your final outcome on this. You batch cases, and then let's say you agree to go to independent review or an arbitrator or some other dispute resolution. What is clear now is your level set will not be the plan's interpretation of interqual. It will not be the plan's interpretation of Milliman, if they applied it, if they didn't apply it. What it will be is the inpatient benefit for Medicare. And this clearly and specifically states that the plan cannot deny the basic benefits of Medicare. And basic is exhaustive. You know, it's not the vision benefit, it's not the dental benefit, it's the basic medical benefits of Medicare, that they cannot use these criteria. So your dispute resolution in your contracts, and I think this is where Eddie's right. You know, we need to take this back to our contracting teams, because if you want to dispute, the level set now is very clear. It's the coverage criteria that exist in Medicare. It's what's in the regulations. It's what's in NCDs and LCDs. It is not what's in interqual, and it's not what's in Milliman. And so instead of then getting, say you get a third-party independent reviewer that you agree, you take an at-risk dispute resolution process to a independent review, they're not going to level set against whether or not they interpreted interqual quite correctly. You know, what we should be using our contracts for is what's the basic Medicare coverage criteria. You know, it's what's outlined in the regs, and it's so now we know if Medicare covers it and an MA plan doesn't, we should have an organized fashion as hospitals to be able to say we should escalate this and dispute it, because now it's no longer, you know, all the different plans proprietary criteria and interpretations of that. It's really what is in the regs, which is what we're used to doing with traditional Medicare. So I think that's where I don't think Medicare fully understood the extent of benefit denials that were not reaching their oversight mechanisms of level 2 independent review.
No, and both Eddie and Brian, I think that one thing that really gives me pause when they're talking about criteria and developing internal standards, et cetera, is the complete paucity of medical literature looking at case-controlled, double-blind, randomized studies of treating an acute disease process in observation versus inpatient. I mean, all of this is filtered down and distilled into an MCG guideline or interqual guideline. But when you go back and look at the original studies, none of them actually talk about the place of service for those disease processes, and yet they're being used to determine, and will probably continue to be used to determine or support observation or inpatient. There was never the intent in any of those studies